it seems to me that bevacizumab in non-squamous, non-small cell has kind of had its ups and downs. And what are people's practices now? Roy, how do you use Bev in the first-line setting in the non-squamous?
Well, I've changed a bit. You know, I used to use it all the time, and now I'm a little bit more discriminating. You know, my sense is that using carboplatin pemetrexed is probably almost as good, or if not as good, as using carboplatin paclitaxel bevacizumab. I guess the choice would be, do I add bevacizumab to carboplatin pemetrexed?
A la Point Break.
Point Break, which you know very well.
Yeah.
And my sense is, in someone with a really good performance status, perhaps a bit younger, I do that. But in someone who's a little on the margin, a little older, I've stopped doing that. Do you agree? Is that the right thing?
Yeah, what I was going to ask you is, do you have a sense in 0819, that was a trial that allowed Bev to be used if docs thought it was indicated. Do you know what percentage of people actually got Bev?
Right, so that's a very interesting aspect of 0819, because we said patients are either Bev appropriate or are inappropriate.
Yeah.
And the inappropriate could be determined because they had squamous disease or based on physician discretion. And it's about equally mixed. So it's embargoed, so I can't discuss it now, but that's going to be a very interesting aspect of the trial.
Right, and the other interesting aspect, I don't know how long this trial was open in SWOG, but it seemed like it was a number of years.
This trial, well, it was 0819,
okay.
Which means I got it through NCI, the panels by 08, but it actually was conceived of about 06. But it's been open now for about 7 years.
It would be interesting to look at use of Bev the first half of the trial versus the second half of the trial.
I think, and you know, this was a true intergroup trial. There are probably as many patients from your group on it as from ours or from some of the others. We're going to be able to mine these data for years.
Mary Jo, what about Chicago? What's the prevailing opinion about bevacizumab in Chicago? The home of the Point Break regimen, right?
We participated in the phase 2 of the
Patel regimen.
The Patel regimen, carboplatin, pemetrexed, bevacizumab, and the phase 2 data looked outstanding, with a median survival of that group of 13.9 months, I believe it was. And we were early adopters of the triple combination until the Point Break trial came out. I personally am using Bev more with the paclitaxel backbone, and I feel comfortable giving patients, even if they're a little bit younger, platinum pemetrexed and omitting the bevacizumab.
This side of the panel, use of Bev in the first line, obviously wild type, non-squamous, non-small cell.
I still like giving Pem Carbo Bev to patients, or Pem Cis Bev, and then continuing Pem Bev maintenance. So if they're not going on a trial.
So you use both drugs maintenance for how many cycles?
Open-ended.
I see, because the one thing that always confused me, the bevacizumab I'm comfortable giving for longer periods of time, but
the PEM can be tough.
The PEM, giving the two of them together for long periods of time can be tough. Yeah.
I agree. I feel like the patients that had been on the combination for a
New
long
Yorkers
time,
are tough.
I was dropping off one of the two.
The doctors are the patients. Remember, we're the doctors.
I tend to drop the Bev before I'll drop the PEM, though, because I do think the data on PEM maintenance is stronger than the data on Bev maintenance, though that's an ongoing study that needs to be read out.
Right.
I won't give Bev with cisplatin. I might give it with carboplatin, but more commonly I'll give carbo and PEM alone. And in a more motivated, good PS patient where I'm looking for a response, I'll consider adding the third drug.